So our very first speaker will be introduced by John.
Okay, great. We'll be hearing from Dr. Manal El-Said, who is well known, of course, has already spoken to us earlier today, and probably had all of her accomplishments and qualifications outlined there. But so I'll just turn it over to Manal in the interest of time. Welcome, Manal.
Thank you, John, for your kind. And I'll try to be not repetitive and think differently for this presentation. It's going to be on vertical transmission, maternal care, and family care. And I'm going to focus mostly on family care. This is my disclosure. And just a little bit of background, the current PMTCT programs only target medical interventions during the perinatal period rather than considering viral hepatitis a family disease. PMTCT offers an opportunity to broaden prevention measures for the whole family and improve access to diagnosis and care. And although prevention of vertical transmission is crucial, we have to consider the family environment that can enhance the prevention of mother-to-child transmission. And in fact, the family-centered approaches has been well known for HIV for more than a decade. But it has not been tackled yet in viral hepatitis, and this should be a great entry point for elimination of viral hepatitis. It presents a fantastic opportunity. And I'm going to address the problem in a different way. Why do we need a family-centered approach? Because of the importance of family in Africa, because of the existing infrastructure of PMTCT programs, maternal and child health care facilities, family counseling programs, especially for vulnerable populations, and the inclusion of children and adolescents. And just a little bit of a background on the types of families. There are different structures for families in Africa. There are either relationships of descent, this is genealogical, from maternal or paternal side, or both. It can be a relationship of affinity because of marriage, and there are highly diverse marriage systems from monogamy to polygamous marriage with extended families, mothers living in their family's home, or if living in the father's home or the father's family home. And there are also households with several generations living in the same place, both living together, working together with an economic and family unit model. And I think this was key to me as an entry point to this presentation, looking at family from a different perspective. We need to understand how families are structured to be able to tackle families. And then looking at what is available for maternal healthcare services across sub-Saharan Africa. As you can see, across sub-Saharan Africa, maternal healthcare facilities are accessible to all. And there's a lot of HIV centers created for prevention of mother-to-child transmission over many, many years. And we need to invest in what is available in sub-Saharan Africa. Of course, these are repetitive slides. You know the numbers, 82 million with HBV, almost 9 million with HCV. Only 2% are aware of their infections or status. Below 20% target for 2020, lack of population-based surveys and discrepancies in modeling data. And you know all about the mortality and morbidity, and we've heard about this. But we knew as well that we have almost 5 million children with hepatitis B in Africa. And globally, there are around 48 million children infected with hepatitis B. And the majority are infected through either mother-to-child transmission or horizontally post-labor. And this is really important because we don't only have perinatal transmission, but we also have horizontal transmission. And there comes the role of the community in awareness and in communication. Of course, we do have WHO recommendations that are very clear about whom to test and whom to treat and how to prevent mother-to-child transmission. There is less than 10% birth dose implementation in sub-Saharan Africa. And of course, with antiviral therapy, it's very, very minimum for mothers, although the antiviral therapy is available for the HIV-infected mothers, and this is something also we can push forwards. And this is also the coverage of the birth dose. As we can see, by 2020, less than 10% coverage for birth dose, and the discussion has been going on since the morning about the birth dose and how to increase the implementation of birth dose. But looking at this as well, and I think Philippa is here, Philippa Matthews, and this is her paper, and she can answer questions later on, but this is checking 96 studies from 39 countries with 370 participants, and looking at the best modes to control or to achieve the elimination goal. So if we look at here, the right side, this is the one with the vaccination groups. I'm sorry. And the vaccination groups are either those 0 to 1 years infant or child, 1 to 6 or older with the catch-up vaccination. And the same groups naive if we do not do any intervention. And the lines, on the right side, the thick lines, the thickness of the line determines the probability of either acute or chronic infection. Of course, the younger age groups are more likely to have chronic infection if we do not have any interventions. And of course, whether they recover or they proceed to chronic infection. And the interventions are either birth dose vaccination with catch-up vaccination, or in addition to test and treat. And what they found is that with the birth dose alone, or birth dose and catch-up vaccination, we are probably not going to achieve the elimination goals by 2030. We need the test and treat to interrupt both transmission and prevent progression of liver disease. So we need everything to go in parallel. And I think we can hear a little bit more about this study from Philippa after we finish. Families are very important and very important entry point, and it has proven so also in lots of studies from immigrants coming from Africa in different countries. And this is looking at what the CDC has for example, for immigrants from Africa and the family approach with awareness to the whole family, screening, testing the whole family, and vaccination of those who are not infected. And Africa now is under the spotlight. This is a recent article published in Nature by one of the reporters looking at all the challenges in Africa. And definitely we all go back to prevention of vertical transmission and the family approach. How about hepatitis C? Some key facts about Hep C. We do have around 3.5 million children estimated to be infected with Hep C. All those below the age of 5 have been infected through perinatal transmission. Of course, perinatal transmission is mostly happening in the resource-abundant countries. In the resource-limited settings, not only perinatal transmission, but we do have as well the iatrogenic transmission. And it's still happening even in my country with a mass screening program for both adults and children. I'm still seeing cancer children being infected on weekly basis. I get 1 or 2 fresh cases with hepatitis C, with acute hepatitis C. So we're still seeing those in the high-risk population groups, and iatrogenic transmission is still happening, like Fumi said this morning. For pregnant women, we don't have anything to interrupt the transmission from mother to child. DAAs are not approved. There are some studies ongoing. Most of the studies and the financing of the studies and the funding has stopped during the COVID. So most of the studies done are investigator-initiated now, apart from those that have been published. There is an increasing recognition for need to screen and treat hepatitis C in pregnancy. And I think this should be within the guidance of each country according to the burden of disease. It's noteworthy also that there are 3.85 billion women in the childbearing age, forming around 21% of the global population. And we're going to look at the numbers in Africa as well. If we look at Africa from our study, we'll find that North Africa and Sub-Saharan Africa have around 1 million children viremic and infected with hepatitis C and require therapy, and this is also a large number. How about the global prevalence in women of childbearing age? Almost 15 million women in childbearing age are infected and viremic for hepatitis C. And if we look at the map, we'll find that Burundi has the highest prevalence. However, the highest number of infections are in Nigeria, in sub-Saharan Africa. So HCV treatment in infection, it's double dividend. We can cure the mother and prevent mother-to-child transmission at the same time, but most pregnancies are unplanned. There are lots of also other complications. It's very important that we screen and test young girls, and even before conception and before marriage and before pregnancy, and treat them as early as possible for hepatitis C. We should not wait until they become pregnant. Of course, there is always cost of diagnostics and safety and acceptability. But there are several other approaches to include women and also to include families, like a macro-elimination program like what we've done in Egypt, screening and testing everybody who's above the age of 18 and then going for a school screening program for above the age of 12. And it's still ongoing, the school screening on a yearly basis. Those who have not been tested, we are testing them every year. But there are also other models like villages, rural communities, looking at a village by itself and screening the whole community in the village and making awareness messages, and also doing a lot of surveillance and testing after we educate and test and treat. They also have a program for surveillance to make sure that those villages are completely hepatitis free. We also published a nice model for micro-elimination of hepatitis C through testing of Egyptian pregnant women presenting at delivery. And we recruited those above the age of 30 years, those with a history of abortion, blood transfusion, all infants of those who were diagnosed HCV RNA positive from the population that we tested, the antibody positive were negative. And women were referred for DAA therapy immediately after the conception. And I think that's a nice model as well, because if you cannot treat mothers before conception or during pregnancy, you can at least link those mothers to care, and they can access treatment after the pregnancy. And all mothers testing positive in this study access treatment and were cured of hepatitis C. This is another model that we've published from our database. Of the large database with people who have been treated, we found 100 women who conceived during DAA therapy. They conceived by accident, and the majority stopped immediately, but some of them stopped after 4 weeks and even 6 weeks, and those were completely cured of hepatitis C, and it was soft, the Klatters-Wehr. We've seen only one congenital anomaly, which was not different from the general population, an atrial septal defect in a child. But we've seen a couple of, one with postpartum hemorrhage and one with also antepartum hemorrhage. But however, this was not different when we compared to the general population. Now Egypt has the triple elimination program in certain facilities in maternal and child health care centers only. It was introduced last year. So far, almost 1.5 million have been screened for HIV, HPV, and syphilis, and the cost for the RDT for all three is only $1. And all those who test positive are referred to the national centers for either hepatitis B or for HIV. For the Ministry of Health, they have special centers for HIV patients, and syphilis patients were also referred to the Ministry of Health hospitals. But there are several models also in sub-Saharan Africa of integrated maternal health centered care for scaling up hepatitis interventions, and the latest was one from Namibia for prevention of hepatitis B mother-to-child transmission, and we've seen this AVERT study also from DRC last year. And there are several studies ongoing now for interruption of mother-to-child transmission. But I would like to also mention that this is a fantastic opportunity not only to test the mother or prevent mother-to-child transmission, but also to counsel the family. And there are several models for family counseling that we can see from the HIV. And this is, for example, one model for the counseling, family counseling for HPV and HCV. They make sure that the mother brings the partner to the center to be counseled about hepatitis. And these are some of the transmission risks that are discussed with both the mother and the partner, and for both hepatitis B and hepatitis C. And also, these are the risk of transmissions sexually for hepatitis C, for example, according to the key population or the vulnerable population. And this is always discussed with both the mother and the family. And also, if the partner is positive, then he goes through the cascade of care. If he's negative, he has to be vaccinated, and then we screen the rest of the family. We call upon the rest of the family as well to screen everybody, and once they are negative, we can vaccinate. We've been adopting this process for many years, and now through our national program, of course, it was a macro elimination program, but before that, when we were treating children, for example, I've been treating children for many years, I used to counsel the parents and counsel the child himself. And then we screen the rest of the family, whether for hepatitis B or hepatitis C. And whoever is positive is linked immediately to care, and who is negative for hepatitis B, we vaccinate. And I think this is a very, very important approach, and I think physicians have to be very well engaged and trained on counseling the patients, whether it's a mother coming to the maternity centers or they are patients coming to your centers for treatments. And you have to counsel them for family screening. And these are some examples, for example, from one of our projects that's supported by civil society. I'm Secretary General of this Egyptian Liver Care Society, and we support children with treatment for hepatitis C since 2008. And when we started with DAAs, we have centers all over Egypt in different universities. We fully equip those centers, and we treat children. We make awareness programs and for the families as well. So we sit with the families, regular awareness on prevention methods, how to protect themselves. We test the families as well. And we distribute prevention material to the children. We give them clippers and scissors and everything that they need, even new toothbrushes when they start their treatment after they achieve sustained virological response. Program, including the awareness and the counseling part, successful program because you make sure that this. So it's important not only because you're engaged and access to treatment, but it's important as reinfection. So this is very important. We have a very nice program in universities since 2000. Was in 19 universities all over Egypt. And we've worked with more than 100,000 students. I had 6,000 volunteers of the young people working with me. We vaccinated 30,000 students against hepatitis B, and we distributed more than 100,000 coupons, discounted coupons for students to go and get the vaccine at a very discounted price. And this was an entry point for, as well, that they awared their families. And we were telling them at the beginning of the campaign that they are our troops in the community. They can go and spread the awareness message around them in their homes, with their neighbors, with their families, and it really worked wonderfully well. There was a huge media coverage at that time, and we continued having coverage in the media. And I'm going to show you here, we had an actor, an actress on the left side. At the bottom, we have here a famous actor. He actually is an international one. His name is Amr Waked. And he was standing in the booth. He was distributing the awareness message himself to the students. And there was a huge advocacy from the media, from the public, and we had also a very famous actress with us in this campaign. And the students were very much empowered. And then we had another one, the one on the right side for hepatitis C. It was a test and treat one. We used the students from medical schools, and we were testing them and treating whoever was positive, and they were going to spread the awareness messages in other universities as well, and giving lectures themselves. So it was training of trainers, and then you spread out the message everywhere. And in the middle, here is my favorite, was Sesame Street, the Egyptian Sesame Street. That was the awareness message that I worked on with this a very nice TV show. And I introduced a lot of awareness, nice awareness messages to children in the script of Sesame Street. And it was really a fantastic experience. I really enjoyed it to a great extent. And this is my final slide, just showing what they are doing in HIV and how we can invest and use this for hepatitis as well. In HIV, they have a complete sero-ecological model for retention of women in care, to make sure that they're retained in care, they're not stigmatized, they don't have any social pressure from the environment, from the antenatal clinics to the postnatal clinics, to the prevention of mother-to-child transmission, to the partner support, to the stigma and disclosure. Everything is in this model. I like this model very much, and I thought that would be a nice ending for my presentation. So I think that's what we need. We need to strengthen the maternal health care facilities and educate the physicians and those working in those facilities to counsel patients and families. We need a family-centered approach in maternal and child health care centers. We need to train the healthcare personnel, and we need a country-based tailored guidance for access to care and treatment. And of course, universal health coverage with the part of awareness and education and engagement of all stakeholders to prioritize women in childbearing age within the cascade of hepatitis B and C for triple elimination. Thank you very much.
Thank you, Manal. We have a few minutes for questions. I have a question over here from John.
Thank you, Mr. Chair. Thank you, Professor Manal. So I just want you to give me a clear perspective. This is a very important topic you're putting, the family approach towards hepatitis care and the eliminations. So you cited some models of how HIV model worked, and it seems like it's a separate entity. Now we are advocating of integrated services. Mm-hmm. And one slide I saw, you put the integrated maternal child health care. I don't know to what extent in Egypt, but the advocacy now is to have integrated, viral hepatitis care using the existing infrastructure, to diagnose and treat. And I see this is how the maternal, the family concept is going to be successful. But if we copy the models of HIV and STIs, for example, and they create another, system, probably it may not be sustainable. Recently in Tanzania, for example, we got a buy-in from the Ministry of Health to integrate hepatitis services into National AIDS Control Program, for example. And in this aspect, we expect, because HIV is an outdoor service now, TB, malaria, all these mothers are targeted for these kind of services. So I don't know what is your take in this. Do you emphasize on the integrated services, and the nation can copy on this, and we can have a platform that champion this kind of a policy, and I think we can make some success from what you say.
I agree with you 100%. I am with integration, because we can use the existing platforms to our benefit. And already when I showed how many maternal healthcare services are in sub-Saharan Africa, the majority of them are doing PMTCT. I think investing in those maternal healthcare centers is a big opportunity, and using the same approach that they've been using for more than a decade for HIV. That would be the best way for on the road to.
Thank you for an excellent talk.
Just please introduce yourself.
Oh yeah, Mike Vinegar in Malawi. And we're also working on one thing that I wanted to get your feedback on is how stigma that happened in the early years and the link with sexual transmission in the family approach, because I do worry that if you just tell the hepatitis before they're ready, they might stigma, leading to more stigma around hepatitis, which is how we educate our patients. Get your thoughts on that. Is there a potential pitfall of educating health workers about the differences?
I guess you're absolutely right, and that's why I'm saying that training is very important. I do this kind of time for families with hepatitis B, and I have children, and now they're married, and they come to me for counseling, and they bring their partner before marriage. That it's absolutely safe. You can get vaccinated, and you will be infected if you get the vaccine. So I think of removing the stigma, and Africa has a very high has to go through several parallel programs. One of them is through the media. It is a real tool and a very important because the media can spread the message around. Prevalent in a lot of families, you can protect your family, and some awareness on how to vaccinate your family. And I think that's very, very important. So it needs a lot of work, and I think the group here today are all working in programs like this, and the community, we have a very strong community representation, and the community should work harder and should work with the media on removal of stigma and discrimination. Thank you.
Time for one more question. I had one question. So it sounds like you're already doing somewhat of a family approach for hepatitis B. Do you have any data to show how many people get tested and benefit from that family approach? Have you had an opportunity to do any type of study in that regard?
We have the data, but we did not collect the data. But I think we can do this. It's a good idea. We can do this, and we can do it also at the level of the national centers also, because we request when somebody is hepatitis B infected and is referred to one of our national centers for treatment, we request family screening and vaccination of the negative, so we can get this kind of data from the database.
I think that would be really helpful to get that pragmatic data. Thank you.